Hello, my name is Shannon Bohannon, and I'm going to be presenting an oral case presentation today on a 69-year-old female, the initials PH. She presented to the clinic today with reports of a hoarse voice for the past 3 months. Um, Her history of present illness is that she reported progressive hoarseness over the last 3 months. She described her voice as raspy and weaker than usual, and she noticed that the hoarseness kind of worsened if she was speaking for prolonged periods of time. She reported she did not have any pain. Well, um, any pain with speaking, but she did report a mild sore throat, but she did not have any difficulty swallowing. She reports she has no history of an upper respiratory infection. She or denies any exposure to anyone who's been ill. She is reporting she does have an occasional cough when she eats and that she is having some mild to moderate throat clearing throughout the day. She has not had any significant weight loss, any hemoptysis, or any kind of night sweats. So review of symptoms, subjective. She did answer all questions appropriately. Was her own historian. She did provide a thorough history of her present illness. Our HEENT exam revealed that she did have a hoarse voice. She was doing some intermittent throat clearing, and that she did report a mild chronic cough. She did report a mild sore throat, denied trouble any swallowing, denied any dysphagia. Cardiac wise, she denied chest pain. She did report mild intermittent discomfort with GERD. Respiratory, she denied dyspnea. Mild cough, reports a mild cough. But she did have some mild, but she denied any kind of dyspnea. GI-wise, she denied any nausea, vomiting, diarrhea. She denied abdominal discomfort, and musculoskeletal, she did not have any joint pain, and she denied any discomfort. Her past medical history, she does have a history of hypertension. She has a history of type 2 diabetes with peripheral neuropathy and chronic kidney disease stage 3. She has a history of depression, hyperlipidemia, and GERD. Her surgical history, she did have a hysterectomy in 2001. She is married. She's a retired school teacher. She has never smoked. She denies alcohol use. She does consume caffeine in the morning, although she reports it's not very much. She denies any oral tobacco use. She is not allergic to any medications. Her current medication list includes sertraline, 50 milligrams daily, metformin 500 milligrams twice a day, gabapentin 600 milligrams twice a day, lisinopril 10 milligrams daily, atorvastatin 20 milligrams daily, aspirin 81 milligrams daily, multivitamin a day. She does self-administer Lantus 10 units each evening. She does take omeprazole 20 milligrams daily. She also will take over-the-counter acetaminophen as needed for any kind of treatment for headaches that she does report she occasionally has. Her current objective assessment is her vital signs are 132/78, heart rate's 100, respiratory rate 16, her temp is 98.4, O2 sats 97% on room air. Her weight is 204. She is 5 feet tall and she has a BMI of 40. Physical exam general, she looks well nourished. She's alert, oriented. She does not appear to be in acute distress. HENT exam revealed no oral pharyngeal lesions. Her nasal mucosa is non-edematous. Oral mucosa is pink and moist. There is no lymphadenopathy. There is no erythema to her sore throat. Tonsils are 1 plus. Her thyroid is not enlarged and there are no palpable masses. Her lungs are clear to all fields. Her heart rate, heart sounds are S1, S2 is normal. There are no murmurs or gallops or clicks. Her voice is raspy. It is breathy, and she does fatigue easily after some prolonged walking. She has her gait is steady, no abdominal pain, no mass is palpated. She denies any abdominal discomfort with palpation, no hepatosplenomegaly, no CVA tenderness. She denies any dysuria. And so we're going to move on to our differential diagnoses. So this diagnosis today will be presbyophonia. The initial would be an age-related vocal cord atrophy. Differentials for that could be a vocal cord fold paralysis or paresis, or laryngeal carcinoma. The carcinoma is a minimal, less likely risk due to the fact that she has no risk factors, considering that she does not smoke or use any kind of oral tobacco. Diagnostic workup, we're going to make a ENT referral for possible laryngoscopy for diagnosis. To further diagnose the presbyophonia, we're going to do a CT with contrast to look for any kind of masses or structural abnormalities. And then we are also going to do a CBC, a CMP. We're going to do a TSH, T3, T4, A1C to just assess any kind of thyroid abnormalities that maybe were not assessed on physical exam. Treatment plan. So when we developed this treatment plan with Miss PH, we considered AAC an Essentials Domain 2, which is person-centered care. Now, considering the fact that she is a retired teacher, she is a social person, she does enjoy speaking, she does enjoy using her voice frequently, and so we involved her in deciding her plan of care and what she would like, and to determine her goals for improvement and to determine her willingness to improve. So she did say she was willing and open to try any therapies, any kind of referrals that needed to be made, and any kind of vocal exercises or vocal needs. She's willing to implement them to improve this. So one of the first things we're going to do is make a speech language pathology referral for voice therapy. And then maybe to put her on some vocal exercises to improve glottic closure or breath support. We're going to do lifestyle and supportive measures, humidifier use, and at this time, until she can get in to see the ENT, put her on vocal rest with the avoidance of prolonged speaking, and maybe to just at this time use a whisper when she is speaking, and to avoid the excessive throat clearing even when she feels the need to do so, and to stop her caffeine use in the mornings. Medications, we are going to continue the omeprazole for her GERD treatment to minimize the laryngeal irritation, and then we're going to provide further education on her reflux precautions. And then we are going to plan to follow up with her in approximately 6 to 8 weeks after she has had her ENT appointment and after she has received her speech language pathology treatments, to see if there's any kind of improvement in her voice. We educated her to monitor for any red flags, such as worsening of her hoarseness, any kind of dysphagia, or any kind of weight loss. So this completes my assessment for today. Thank you.